Well, thank you guys all for taking the time to do this. I know some of you guys are in the training class, others have come separately. So hopefully this topic you'll find relevant. I'll start just introducing myself. I'm Heather. I've been volunteering at Samaritans a little over 4 years or so. I volunteer and home lead, and I also work as a nurse practitioner with folks with psychotic disorders on an inpatient unit at McLean.
And I'm Steve Fidelli. Heather and I work together on one of those units together. And I also coordinate a groups therapy program. I'm a peer specialist, and being a peer specialist means that I've had lived experience and lived experiences with psychosis. I've had schizophrenia and bipolar disorder for about 15 years now. So yeah, we're here to talk about these things, and yeah, we'll go to the next slide, I guess. So.
Yeah. So what is psychosis? So if whoever's comfortable, if you want to take yourself off mute or maybe put it in the chat, just starting to get a sense of where you guys are at, but also see if anyone, what you guys know about psychosis. Does anyone feel comfortable saying what you think psychosis is?
Disconnection from reality.
Great, yeah. And I see, go ahead.
Yeah, there were a few things in the chat as well. Yeah. Some type of break from reality, a loss of reality, delusions, paranoia. We'll get to that language in a moment. Not knowing what's real or not real. Yeah.
Great.
Mm-hmm. Mm-hmm.
Thank you, guys. Yeah, that's essentially the definition I have here. Essentially, when someone perceives or interprets their reality differently from what most people are perceiving around them. And so when we think about psychosis, I think oftentimes we think about mental illness because it can be a symptom of mental illness. But there are a lot of different types of psychosis. As Steve said, we're going to go through some of the language in a bit. But things like hallucinations or delusions, paranoia, those things get categorized under psychosis. So when we think about hallucinations, essentially a experience involving your senses. So visual hallucinations would be seeing, or auditory hallucinations, hearing. People can have like tactile, olfactory hallucinations, which are feeling, smelling. Delusions are essentially beliefs, so beliefs that differ from others around them, and paranoia are usually fearful beliefs, essentially. That's how I think of those. And when we think about causes, as I said, coming in with mental illness, so diagnoses like schizophrenia, bipolar disorder, depression, PTSD, trauma, those things can have psychosis associated with them. There are also substances, whether like prescription medicines as a side effect, psychosis can come about. Illicit substances like stimulants, cocaine, hallucinogens, those things can come about, psychosis can come about. And then medical causes too, epilepsy or seizure disorders, a brain tumor, stroke, dementia, Parkinson's, to name a few, but there are kind of a lot there. So that's an overview from a kind of clinical standpoint, what psychosis actually is. And so thinking about why this is relevant, why we're even presenting on this. So about 3.5% of people in the US will experience psychosis some point in their lives. And to compare that to other statistics, about 2.3% of people experience OCD, which is something that I feel like is more kind of or somewhat commonly known. And then just to throw like a medical statistic in there, about like 2.5% of people have kidney disease, which, probably know someone with some kidney disease or have heard of that at least. And so it's a good number of people in the US. There's the population being like 300 million or so. So we're talking about like 9 million people or so. And then we're a suicide prevention hotline, so relating this to suicide as well. So about even 1 or 2 in 5 people with a history of psychosis will attempt suicide. So that's about 20 to 40% compared to the general population. It was hard to get exact statistics, but that's about like 3% of general people. So much higher instance of suicide attempts among folks who've experienced psychosis. And then invalidation is a really common experience for people experiencing psychosis, having heard from others that they're not believed or that their concerns aren't real. And so these folks may be seeking out, people that will listen, and that's really what Samaritans is here to do. And so it's even more relevant in the way of what we do. This is a really important role. It's important to provide validation and listen to people about their experiences. In reviewing, some of the call reports and things prior to the presentation, it's also, I want to point out the relevancy and the fact that this isn't a, hypothetical presentation like this might be helpful. This is something that we do see on calls, people, whether they call it psychosis or not, but that are struggling and bringing up these experiences. And so that's why it's particularly relevant for Samaritans and you folks volunteering.
Cool. All right. So a little about cultural competency and just generally a good approach to, to take when you're on the phone call. So cultural competency does not make us experts on people or their experiences in their lives. I've had experiences with psychosis for 15 years. I'm a program coordinator at the hospital, and every single individual I work with, I approach with a beginner's mentality, right? Like I've had years of experience with these things. I've done years of writing, years of a number of things, but having all that knowledge, whenever I'm meeting with each individual person, the way they experience their psychosis is different. So I think cultural competency as well is kind of saying like, this might be something I know about or I have an understanding of, but I need to have like a beginner's mentality. I need to ask questions about it, not make assumptions, not make assertions, not diagnosing. And that's like another part too, as, on the call, we're not going to be diagnosing anyways, but, in your mind, even when I'm working with people, there are a number of people, I don't know their diagnoses. We just talk about what's happening. I just listen to what's happening, and listening to what's happening for them is really what's helpful. So this being said, talking to people with psychosis is the same as talking to everyone else we know. It's no different. But if you are kind of speaking differently, someone might pick up on that, and that can be distressing. If you have a different tone of voice or different language or a different way of interacting with them, all those things are very noticeable, especially if you've had psychosis or any mental illness for a number of years. You can immediately kind of pick up on it, and that can be distressing in itself. So then again, if we're gonna kind of make assumptions, the assumptions you want to make are that people's lives are exactly the same as your own, right? So I've had schizophrenia for over 15 years. This is my condo. I work full time. I have friends. I go out when it's non-COVID time, we won't go there. So all the thoughts, the emotions, the ideas, the life goals, the family dynamics, you can assume the same things for someone, in the position who you're talking to, who might have psychosis, or like, generally on the call, you're probably not going to hear, I have schizophrenia or I have psychosis, but you'll hear elements of what's happening. So, given that person's, given what they're telling you, you can make the same assumptions about them as you would any other person. And that's pretty safe to do. Realizing people have commensurate lives and abilities to ourselves. I think another one is no hierarchy, no heroism, and no aggrandizing. So hierarchies can be a common thing where there can be an assumption of less than or otherness or being above people when they've had psychosis or mental illness. And that's something we definitely want to avoid. Realizing that there should be equality, and there is equality between all people when we're on the phone. And I mentioned no heroism. America has this huge hero complex, and I think I don't see the commercials in the rest of the world, but it's like this big thing to like go out and be a hero and like save someone and to like, save the day or save the life or save the game. But like, you don't need to save anyone. That creates a hierarchy in itself of, I'm above and you need my help and you need my saving. There's a concept in psychology called witness. So being with someone, and that's something on the call that can happen. You're just with people, listening to them. We're not diagnosing them. We're not practicing therapy on them, as for any number of reasons, but just being with and being equal to, those are important things. And there's nothing to be afraid of, right? Like, number one, you're on the phone, but number two, no one, people who have had psychosis, percentage wise, are a lot less likely to be violent towards you than, or to anyone, than people who haven't had psychosis. There are percentages on the violence. Heather will get to that later. I might be stealing one of her slides, but so yeah, we'll move on. And all right, yeah. Okay, so I think the important thing, human experience language is a kind of language to talk about mental health experiences, right? So notice how I'm calling them experiences and not mental illness. Labels can be really powerful, right? Labels can change the way we perceive people, the way we talk to them, the way, they're treated. It can change a huge number of things. So being really careful with labels, number one, but number two, separating the person from the label. So with human experience language, as opposed to saying someone had delusions, that could be someone's genuine belief in that moment. So thinking of it as a belief, right? We'll get to the examples afterwards, but you want to separate the person from the label. Again, having a diagnosis doesn't indicate who someone is or their personality type. Having bipolar disorder might mean my emotions swing higher or lower than, the average person. It's just generally a lot of people categorize it as having a wider emotional range, but that doesn't say anything about who I am, my beliefs, my character, my identity. That's just something I experience. The same way experiences of psychosis, they're things I experience. They're not who I am necessarily. Or at all. So again, thinking about word choice, using connotation effectively. So denotation is the exact meaning of a word. It's like, it's a sunny day would mean, the sun is in the sky and it's really bright. Like, that would be the denotation. The connotation of a sunny day would be like, I feel really good. I'm having a sunny day. Like, things are great, yeah. So when I'm thinking about word choice, I think about what kind of connotation or what's the meaning surrounding the word. And that helps me to figure out which words to use and also which words I don't want to use, because I don't want to ever hurt someone's feelings or insult them. And language can do that sometimes, but language can also make people feel good. So eliminating us and them type statements. We're not wanting to separate people who've had psychosis from the category of people who haven't had it necessarily. It's one of the biggest forms of stigma in mental illness is otherness. And when people kind of perceive, statements of like us and them, or, there's like this strong delineation between your camp and their camp, like, people pick up on this. They're fairly intelligent, and that can feel damaging. Clinical language can be a power language. So, just kind of realizing that, like, we're not diagnosing anyone, we're not clinicians, and generally, even at work, Heather and I, we're always taught to use the language that the person is using. Generally that can be a good rule of thumb, but it can also be good to ask, like, how do you want to talk about this? How do you, what's some language that you want to use? And just realizing identity, that the way language is used is going to factor into someone's identity. And it's always really important to be aware that identity is strongly intertwined with mental health. So wanting to use words that help someone to construct a positive identity. We don't want to use any pejorative or negative words. So these are some examples. Psychotic or psychosis, I have, what does this word even mean? And I'll tell you the reason for that, because there are so many different there are so many different symptoms that can be categorized under the umbrella of psychosis, that if you say this person had psychosis, then, you know, it could mean any number of things. Someone could be saying, oh, their psychosis was happening, but what does that even mean? Were they hearing voices? Were they seeing things? Were they having beliefs of being a messiah when we know, the world's not being saved right now? Like, it's just not happening. Were they fearful or paranoid? So, the language on the right is just some like softer, kinder language you could use. The language on the left, for a lot of people, can sometimes be really stressful to hear. So just to keep that in mind. All right, and so this leads us to stigma. So, kind of one of the themes I've been talking about is stigma, but also self-stigma. We don't want to feed into this, and language is a big part of it. I think doing the work on our own time to realize, the equality, in dispelling pop culture notions. Most people are safe and friendly. Most people have normal lives. A lot of people have, we have vocational and college groups, like a good portion of people in my program are working and they're going to college. I work with 18 to 30-year-olds primarily. We're not any better or worse than anyone for them having a mental illness. The one thing that can be really common to be like, oh, I'm better than this person. But another approach, sometimes people will be like, I'm going to put myself beneath them. But both are kind of sense, just kind of, I guess the root is to just be yourself and talk to people the same way you would talk to everyone else. I mentioned otherness early, but just to reiterate, people who've had mental illness or mental health struggles are not separate entities from society. There might be symptoms that we've experienced from time to time, but the personalities are all the same, all different types. But so the over positivity, if you're naturally a positive person, this is good. But again, otherwise just be yourself. You don't have to be overly kind or caring or considerate. Those are things that people a lot of times in the groups I facilitate will be like, I sense that from, my family member or this person I know. And that was really distressing. And then the biggest one is the way you talk about people when they are not there will make its way into the conversation when they are. So, in your personal lives, right, when you're talking about psychosis or you're talking about mental health or mental illness, it makes me question, why would you want to disparage someone to begin with? But when you hear those disparaging conversations, not feeding into them, not being that person who's saying the stigmatic things. And also in your call notes, the language you use in the call notes is really important in terms of the way you're framing, the way you're thinking about the person you're talking to, but also the following people who are going to read that note are also going to be ingesting that information. So that's one way to deconstruct stigma a little bit.
Great. And I know Claire put in the chat wanting to go back to the previous slide, so I'll do that briefly. And then this is also, we're recording this too, and I'm not sure if it makes sense to even give the PowerPoint out, but we can also do that as well.
Yeah, that would be fine. Mm-hmm.
Great. Moving forward, thinking about how this applies to our particular callers. So as I mentioned, in reviewing the kind of recent call reports, it's definitely evident that this is coming up both in these kind of three ways that I'll go over. So oftentimes sometimes we see callers just saying that they're having psychosis, or maybe they'll mention that they're on a certain type of medicine like antipsychotics, or that they just got out of the hospital, or they have a diagnosis of schizophrenia or something like that. And that kind of clues us into, that they may have experienced psychosis. But again, like Steve said, really, what does that mean? And so, we would want to find out a little bit more what that actually means to them. So we're not coming in with our kind of preconceived notions about what we think it means for us. And then some callers might not realize that what they're experiencing is different from other people's reality. So they may just simply be talking about experiences that maybe you as the listener are able to clue in. It doesn't sound as realistic, or it doesn't align with your reality. So some examples of this, there are a few callers that might call and talk about like the FBI following them, or some organization being out to get them. And when you hear it, realistically, we don't hear, every day about the FBI, or, Steve's example of being a messiah or something like that feels, fairly out of touch with our reality here. And so they may not be aware. And that's another type of caller that may be experiencing psychosis that could come up. And then other times, both of these types of callers or separate callers might just seem distracted by their thoughts, or maybe they're hearing voices in the call and there's some silence where they're listening to them, or I don't know, maybe there's some other clue that kind of leads you to think about psychosis. And so this might come up in all different ways on the calls, and we're in a little bit, we'll talk about kind of examples of how to navigate that. And I think an important point is to remember that the goal is not to stop or lessen or reduce the psychosis. That's not what we're doing on the phone lines, no matter kind of what it looks like or what they're talking about. And so in thinking about suicide, how does the risk assessment change for these folks, or does it at all? I'm wondering actually if you guys would be open to engaging again. If anyone has thoughts, whether you put them in the chat or say them aloud, if you feel like the risk assessment, how it would be different, if at all, for these folks.
I had one person that I was talking to who answered like some of my questions, but not all of them, because he was having trouble like keeping just like thoughts he was having like straight. And so I couldn't get like a complete profile. But basically what I did is I just took a look like at the language he was using, and just kind of kept an eye out for anything that might suggest like suicidal ideation, or that his plan was bigger than like what he'd already described. Yeah.
Yeah, so that could be an instance of someone, their thoughts are maybe more scattered, they're having trouble following. So trying to kind of follow up, re-ask the question or rephrase, and always looking for kind of signs if they bring up suicide on their own, or they change their plan, or their thinking seems to change mid-call at all. And then Claire put in maybe offering care for family or emergency services would have to be done more sensitively. And we can definitely talk about that in one of the examples, thinking about what might be different when if we have an IR call with folks like this. Great. Thank you guys for engaging a little bit. I think, so in part, this is a bit of a trick question in the sense that, it really shouldn't be different unless otherwise things come up. So and this is with the risk assessment, not necessarily offering help or those types of things, but just in the questions we're asking, are you feeling suicidal today? Have you thought about how you might? Have you thought about when you might? Those are all, we should still be asking those. And so things shouldn't change in that way unless it's to adapt if they're distracted, or if they're having trouble kind of following through that. Which applies to people not experiencing psychosis too, right? Depression and other experiences can cause distraction as well. And as I had said, about one to 2 in 5 people with a history of psychosis will attempt suicide. And so this is, when we think about risk factors for that, oftentimes the biggest risk factor for folks with psychosis in terms of completing suicide is, or attempting as well, but is insight. And so when people are just released from a hospital, or maybe their psychosis has improved and now they have some insight into that their experiences were out of touch with reality, and that's where risk does come up. And then sometimes symptoms can make people, just the sheer fear about them, or how distressing they can be, can lead people to want to end their life. And other times there can be beliefs that they need to die in order to help other people, or because they'll be harmed in another way. And so those are other things that come up. And I want to emphasize too, of course, we're not, it's not our job as volunteers to be assessing these risk factors, or, deeming people at more risk or less risk differently than we do through our regular risk assessment. But just to have in mind that some of those things are why, or might be linked to the increased instance of suicide among these folks. And then, as Steve said, stealing my slide a little bit, but with the homicidal ideation, these folks are not at more risk of being violent. Actually, they're at higher risk of being victims of violent crimes. Folks with psychosis, there's no more risk that they'll be violent towards other people. And that's unfortunately a really horrible stigma and myth that gets portrayed often. And so with homicidal ideation, the same as the typical kind of Samaritan's approach will be done with these folks as well. So no big differences there. And so going on to examples, I'm hopeful that if anyone is still awake here, that we'll be able to talk through some of these aloud. And with training, hopefully some of the reflection, validations, and questions will be fresh in your mind. So this is one, some of these actually came from call reports that in callers that I know of. Other ones I've made up in a sense that knowing that these may come up, or likely have come up in the past. I just didn't stumble upon the reports. But they're not exact. I changed some info so as to keep confidentiality. But maybe a caller will say, having experienced fear, beliefs that people have been harassing them or bothering them. They might say, I can't take it anymore. These people have been harassing me for years. I'm wondering if people have thoughts, whether in the chat or out loud, about how we might be able to respond to this.
I mean, personally, I would just respond to it, at face value. Whether this is a perceived harassment or real, someone actually with a physical stalker, I would treat them the same and just ask them about how they feel about being harassed for years.
Great. Yeah. Someone in the chat said, must be hard to have to deal with harassment for so long, or it sounds really awful. I can't imagine what it would be like to deal with the harassment for so long. So yeah, essentially not our job to know whether this person is being harassed in our reality, or if it differs from ours. And so those would be great responses. And as I talked about at the beginning as well, the invalidation is really a kind of a big piece here, right? People likely, the caller may have been told, no one's harassing you, no one is doing this. And imagining really what that feels like is helpful, I think, in thinking about shying away from saying invalidating things, which obviously we would never intentionally be doing. Another example, this one actually is more kind of from an experience that I've had, but they're breaking into my house. I'm not safe. No one will help me. And this can, with a caller on the phone with high emotions, this can be a difficult call because we want people to be safe. And like I said, it's not really our job to assume whether someone actually is breaking into their home or not. At the same time, in this instance, maybe there are things that led you to think that this isn't real or this might be part of psychosis. How might you respond? Great. So someone in the chat said that must feel so scary and helpless. Okay, I'm right here for you. What does help look like for you? I can hear that things feel really unsafe right now. I wonder what help would look like for you. Awesome. Great. I think those are really great things, trying to get towards that pain, which is that no one will help them. And that seems like in this instance, a big part of that painful experience. And imagining, if you thought someone was entering your home and you felt like you weren't safe, how scary and awful that would feel. And I think, as someone said, that maybe in an IR call, we might offer emergency services or things differently. I think, in some ways that's somewhat relevant in terms of if people are feeling really scared, we might want to explain to them, what to expect, or that what it would look like to have an ambulance come, or if they're fearful of certain family members, we might offer to call a different third party or finding out who they're comfortable with. At the same time, those are things that are the case for people without experiencing psychosis, right? It's good to kind of know what to expect if emergency services are going to come, and there are plenty of people who probably don't like some of their family and like others, and so those would be the case with anyone. And I think it's important, especially as a clinician who works in the hospital, people come through emergency rooms to get to inpatient level of care. And a lot of times those people call emergency services themselves. And so, people experiencing psychosis are not less capable of calling 911. It's not the role of Samaritans to do that, even though at times it would feel hard to, we want to help this person. Or if we really think someone is breaking into their home, we might want to call 911 for them to protect them. But unfortunately, that's just not our role. And so recognizing that we can talk to them, we can help them in that way. But if they truly aren't feeling safe, if they wanted to call 911, that's something that they can do in terms of like someone breaking into their home or things like that.
I have a question.
Yeah, please.
I always wonder on that phrasing. I hear things feel really unsafe right now. I wonder what help would look like for you. I always wonder inside that, because is the second part of that turning away from the pain? So I'm often in a quandary as to use the second part of that phrase or to go, I can hear that things feel really unsafe for you right now. What are those feelings like for you?
Mm-hmm.
Can you address that for a minute? Is this the correct forum for that?
Yeah, totally. No, I think that's a really great question. I think it could go either way. And I probably would think about how the person responds to that. And so if they started saying like, oh, well, I guess I could get help, and they're steering out of the pain, that wasn't the intention of asking it. But if they say like, it would look like, someone finally listening to me, like my family would care, then they're kind of steering into what they're missing out on and what they lost, and you can kind of go with that. So I don't think it's like right or wrong answer there. And that happens all the time with me on the phone. I asked a question, I'm like, oh, that didn't didn't go where I wanted, and then kind of ask a different one or switch up the validations. But you make a really good point. We want to make sure that we're not giving like soft advice for them to seek help elsewhere or something like that.
And sometimes for me, it depends on where I am in the call.
Mm-hmm. Right.
If I'm really, towards the end of the call, obviously, maybe sometimes I think it might be good if they had an idea of what help would look like.
Mm-hmm. Right.
And if I'm at the beginning of the call, I notice that I tend to not do that.
That makes sense.
Okay, thank you.
Yeah, thanks for asking. Oh, Sorry, one too many. So I have schizophrenia. So this one we kind of talked a little bit about as Steve was talking about the language and things. And so that doesn't have a connotation to it really. We don't know, is this person happy about that? Are they sad about that? Or is that new? Are they, how do they feel about that? So we not only do we not know the feelings, but we also don't even know what that means to them. What are their experiences that kind of fall under that?
Yeah, I think that's a really good point, Heather, that, I've been facilitating 2 hearing voices groups, one for over 3 years. And a lot of the times people will mention the experiences of voices can be a positive thing. They like having their voices, and that can shift from positive to negative, or sometimes it's entirely positive. Or just to reinforce what you're saying, there are a lot of people who will mention like, no, I'm not really upset about this, or I just want to talk about this. Just.
And imagine if we did respond and we said, oh, wow, that must be awful. No one said that was awful. And so that could really come across negatively.
That is a commonly reported stressor in the group, that people will want to empathize or lament for someone's experiences of hearing voices or having visions or other mental health experiences. And there's more distress from that sometimes than the actual experience. There are a lot of times where people are like, I'm just wanting to talk about this. I don't want empathy or, sympathy, definitely not. So, yeah.
And then the opposite, which hopefully, through the training, we wouldn't be doing otherwise. But then the opposite being overly positive, like steering away from the pain of that, like, oh, that's okay, or that's no problem, or something like that, is essentially giving the message that that person should think it's a problem and they need reassurance around it, when that might not be what they're asking for. And so good kind of follow-up to this would probably be a little less validation, since it doesn't really have many emotions to validate. You could reflect back, or you would probably, the ideal scenario would be asking more questions. Can you tell me a little bit more about that? What is that like for you? Tell me what that means for you, type of thing. How does it feel to have schizophrenia? Great, that's a great question. Kind of getting those feeling words as well. Would you feel comfortable elaborating on what that means for you? I hear you. If you feel okay going into that, what has that been like for you? Great. Those are all really great questions. And then I think I have 2 more. So this one being, I want the voices to stop. I've heard them every day for the past 6 years. You guys have thoughts on things that might be able to say around that, or reflections, validations, things? Maybe as people might be thinking of stuff, I'll kind of throw some things out there as well. So I think saying like, wow, that sounds really distressing. What's that been like for you? David said, if you can put your finger on it, what are you imagining might get them to stop? I could definitely explore a little bit of what they may have tried, and that might open up the distress around not, having tried those things and them not working. It sounds like it would be really challenging to experience something for so many years. Yeah. I think of like, what's the worst part about that for you? Given that they said, they want them to stop, it's kind of implying that it's something that they don't like or don't want. It sounds like that'd be challenging. It must be hard to be unable to have them to stop for so long. Great. And I realized I actually, which I hate doing, but I lied. This is the second to last one. Now there are 2 left. So do you believe me? So in this one, thinking about, I want to be mindful to have a few questions at the end that you guys can ask too. So I'll just go through these ones. This is a really hard question, something that I think comes up for me as a clinician, but also comes up on the phones as well, where you're put in a spot like, do I believe that you're the next Messiah? Do I believe the FBI is in your house? I'm not sure, maybe not in that moment. But we don't want to, that wouldn't be what we want to say. And so saying, I believe these experiences are really distressing for you, or believing the emotions behind them. I believe this is really challenging or difficult. And asking, I'm hearing you ask me if I believe you. I'm wondering, what it's been like with having other people believe you, or what your experiences have been like with that. Is another way to kind of deflect that question and, talk more about the pain and the feelings and less about the reality around it. And then what should I do, or should I ... I mean, this question is not, the response to this is not going to be any different than anyone else asking for advice, right? What should I do about my trouble with my relationship, or what should I do with my family struggles or other things? So what should I do about something about psychosis wouldn't be any different the way that we respond as volunteers for Samaritan. So we know that we don't give advice. And so asking, what do you think you should do? Or what do you feel like your options are? What would that be like if you did that? And kind of returning it back to them. And then of course, if they persist, letting them know that, wouldn't feel comfortable, giving advice. We don't know the situation and exactly, and express curiosity on what they think or what they're looking for with by asking for advice. So those are the examples that I had, and I really appreciate you guys participating too. It's I'm impressed with all those responses. It sounds like you guys are learning a lot in your training, which is great to see. I'm curious if we want to open it up if you guys have questions. I know we only have a couple minutes left, but if any questions came up, Steve and I are happy to field them.
Definitely, we can take a few questions if anyone has any.
This is Kyle. I actually just wanted to very briefly share I had my experience because I think it'll be helpful. So my brother died by suicide in 2007, and he was demonstrating psychosis prior to his death. And I remember it was really hard to know whether to align with his beliefs or not. And I asked him sort of how I decided to handle it was, I said, because I actually ended up asking him about his suicidal thinking. So I said, if I believed what you believe, I think I would feel really hopeless, and I would question my will to live. And then I asked him if that was true for him. But I think that it was really tricky to find how to support without aligning. And so I just offer that language. I don't know that sentence is one we would say to somebody, but obviously my ending is a very sad one, but it still feels like this was relevant to share with you.
Yeah, thank you so much for sharing that. And I think, that's really challenging experience to be in, where, you don't want to validate like that those scary things are happening, but you also don't want to invalidate and, say that, oh, that's all not real. You shouldn't feel hopeless, because as you said, if you were in those shoes, you probably too might have felt hopeless because of how distressing that was. So that's a good example of kind of getting into those emotions as opposed to into the beliefs or the facts around it. Thank you. Maybe one more question if anyone has one that came up, or something to share as well.
I think for me, one thing that I really appreciated, is how much of this seems very consistent and aligns with what we do on the helpline period. There's not that heroistic and heroism mindset. They think a lot of people will come into training, and I hear so often, well, they don't feel better. And the reality is, like, that's not our goal. We're not here to save or to feel better. And so it's such a good reminder, just kind of seeing it aligned so much with what we do on the helpline. And even that beginner mentality, we're not going to pick up the phone, even if you've been doing this for 5 years, and automatically know what you're going to be walking into, because there's so much ambiguity no matter what we do. So much of it was with that beginner mindset. Even if it's someone we've talked to for 5 years and you talk to them every shift, what they're going through that day still might not be what they've been through before. So, going into everything with that clear, non-judgmental, clean slate mindset is so important as well with everyone that we talk to.
Great. Yeah, I couldn't agree more. I feel like a lot of times as I was presenting and as I verbalized too, a lot of this really just applies to everyone too, and wanting that to be, it's another kind of take home, is that we really don't want to treat people who've experienced psychosis any differently than how we otherwise would. And I think the other thing that I think of as well is, hopefully some of this might apply to you guys in your external, outside of Samaritans' lives too. Steve brought up about like how we're writing call reports and then people read those. And similarly, if you're at home, talking about psychosis or people experiencing psychosis with a negative connotation, it's going to be really hard to then come in, answer phones and type up call reports with a different mindset. And so hopefully this will also kind of spread elsewhere as well.
Any last minute questions? I just want to say thank you so much, Heather and Steve, for sharing all of this with us and coming to talk to the class. I know I've walked away with a lot, and I've watched you guys do this presentation twice now, so it's just such a great thing to get to hear and experience. So thank you so much for sharing that with us.
Yeah, thanks. Thanks for inviting me, guys. Yep. Mm-hmm.
Yeah, thanks for having us. It's been great. Thanks for pulling through at the end of a long day as well, guys. Appreciate it.
Of course. All right.